Okay, we're all set. First of all, I would like to welcome our 2018 scholars to the National Training Course in MCH Epidemiology. We're glad you're here. My name is Maureen Fitzgerald, and I am your CityMatch staff lead for the course. On behalf of the CDC Division of Reproductive Health, the HRSA Maternal and Child Health Bureau, and CityMatch, first of all, congratulations on your selection. Thank you for your interest and your commitment to this course. Today should serve as an introduction to the road ahead in the coming weeks. We're almost there. I'm just going to give you a bunch of housekeeping on webinars before we get rolling. First of all, our webinars always begin with your phone lines muted, even our presenters, so we mute and unmute ourselves. If you need to unmute yourself, press *7 on your phone, *7. Press *6 to remute. Or if you have a manual mute on your phone, you can use that too after you've unmuted. But to get into the call, you'll need to, or into the conversation, you will have to do the *7. And then just because sometimes in reality we are multitasking, many of us, some of you may be in a conference room with other people, or you might be typing. There's a chance at some point during the call that we're going to unmute all the phone lines for open discussion, and rather than startle any of you, we'll give you a heads up so that you can, if you're in a busy room, you can quiet the room. Second, at the bottom left is a chat box. Use it to type questions. Both Ashley and I will be monitoring that, and we can respond. Some questions might get held until the Q&A after the presentation. And if you're having any technical or system issues, just use the chat box to alert me, again, Maureen, for troubleshooting, and I'll work it through with you. Third, don't ever put this call on hold. If you have to step out, just keep your phone line muted or disconnect and call back in. We all know what hold music can do if we unmute the lines. So just don't put it on hold. Do what you need to do. Last, if you get disconnected from the phone or the web, just call back, log in, rejoin, no worries. Everything is recorded. It's being recorded right now, and you'll each get an email with the required evaluation, slides, and recording later on today. So that's it for the housekeeping. Now I'd like you to please join me in welcoming the lead project officer for this course, Dr. Ashley Hirai. And I'd like to tell you a little bit about Ashley. Ashley Hirai is a senior scientist in HRSA MCHB's Office of Epidemiology and Research. She serves as a bureau expert in perinatal epidemiology, GIS, and advanced research methods to inform, monitor, and evaluate various programs and initiatives, including the Title V MCH State Block Grant. Dr. Hirai also oversees this annual training course in MCH Epidemiology and conducts applied research focusing on perinatal trends and disparities. Prior to joining MCHB, Ashley worked as an epidemiologist for the Hawaii Department of Health and completed an Academy Health postdoctoral fellowship at the National Center for Health Statistics. I don't know why that word always kills me. She holds a PhD from the Johns Hopkins Bloomberg School of Public Health, and her research has been published in the American Journals of Epidemiology, Public Health, Preventive Medicine, and Obstetrics and Gynecology. In 2016, Ashley Hirai received the National MCH Epidemiology Award for Early Career Professional Achievement. And with that, I will turn it over to Ashley to begin.
Thanks so much, Maureen. Hi, everyone. I'm so happy to be on this intro webinar and to meet you all in person in a week and a half. And it's just a wonderful course for faculty and trainees alike. We learn so much from each other and really come away so much more energized and impassioned to make progress in our field. So with that, I will start this intro. Just trying to move over here. Okay, got the controls. So I'm just going to provide a little background about the course and how to prep, the purpose and history of the course, description of your 2018 class, and what to expect. And then I'll provide a little bit of extra information on other training and data resources and an overview of the Maternal and Child Health Bureau where I sit and select initiatives. So the course purpose and history was really to build state and local EPI capacity. In the late 80s, health departments moved from providing direct services to the core public health functions, assessment, policy development, and assurance. And the Omnibus Budget Reconciliation Act of 1989 then established data monitoring and reporting requirements for the MCH block grant. So states were requesting epidemiology support and training. And in response to that, CDC and HRSA MCHB partnered to meet that need and expand data capacity. We established the MCH EPI Assignee Program, which provides placements to different states, and it's often funded by block grant dollars. We have currently 16 in the field. The Bureau provided state systems development initiative funds to build data capacity, and that's used flexibly by states to support new data systems, linkages, analytics staff, and the needs assessment for the MCH block grant. We also started building the future workforce through funding to schools of public health to emphasize MCH leadership training, applied research, and technical assistance to communities, states, and regions. We have 13 schools funded, and then added a doctoral training grant to support EPI PhD students' dissertations using state and local data. And we have 8 schools. The University of Illinois Chicago is one of them if you're thinking about going back. CDC and the Council for State and Territorial Epidemiologists, the STE, have a fellowship, a 2-year applied fellowship for recent graduates to have a placement in the field. We have 2 trainees that are actually fellows, CSDE fellows this year, Ashley Horn in Illinois and Mi Lee in Portland, Oregon. I'm sorry if I mispronounced that. So welcome to you too. And we also, of course, have this annual training course, and now it's a biannual, every other year EPI conference, and that is now merged with City Match leadership and really combining the best of both worlds in program and policy and data, so integrating data-driven practice. And that is coming up this year in September in Portland, Oregon. So I highly encourage you to try to attend that. So as a result, hopefully, of all these efforts, we have seen improvement in data capacity. This is an assessment done by CSDE. It really shows that MCH EPI capacity has grown over the last decade. So states with at least 50% capacity for MCH EPI and surveillance increased from 43 to 73%, and states with minimal or no capacity decreased from 25 to just 6%. And so between 2009 and 2013, we saw increases in the proportion of MCH EPI leaders with administrative and scientific authority, the percent with master's degrees, the percent with access to various databases, and in the number of peer-reviewed publications and abstracts and other reports. But we still have opportunities to improve. Only 37% of states had full or almost full EPI and surveillance capacity, and only a minority of jurisdictions had MCH EPIs participating fully in policy development and have consistent access to important data sets. Only about half were routinely performing statistical tests, and only a quarter about routinely conducted multivariable analysis. And that's really the purpose of this course, is to build that skill and techniques with multivariable and advanced analysis. So the multivariable methods are really key for program evaluation, and identifying the why and the how of the patterns that we see in morbidity and mortality that tells us what we need to address in terms of intervention. And the most pressing need was for additional staff and training. So we try to bolster both of those, the pipeline and the continuing training of existing staff. So our purpose here, again, in this course is to develop those skills of existing staff to inform and improve programs. We provide the conceptual basis and statistical methods to support needs assessment and program planning and prioritization, performance monitoring and surveillance, and program evaluation. And we do this through webinars, through the in-person lectures on site, with exercises and discussion, and individualized TA. So here is our course faculty cascade, if you will. We have Bill Sappenfield, who will be providing, he's from a leader in the field many of you probably know, who's at University of South Florida, and he'll be providing lectures on needs assessment, prioritization, and quality improvement. We have Pat Ocampo from University of Toronto, who will be providing training on program evaluation, and she also has extensive expertise in social epidemiology. Deb Rosenberg, we're excited to have back with the course this year, being in Chicago. She's a longtime faculty member who retired. And new this year is Mike Smith. He's previously with the state of South Carolina and also has a background in biostatistics. I'll be providing some lectures on absolute and relative measures of association, decomposition, and difference in models. So all of the faculty have a wealth of experience, particularly Bill, Pat, and Deb have over 30 years of experience in the field, and we know you're going to learn so much from them. While in Chicago, we'll also get to see Dr. Kristen Rankin on a couple of occasions. She directed and coordinated much of the course content for the previous 5 years, and you'll see her imprint on a lot of the material. She's just had to scale back her work as a result of an ALS diagnosis, and will benefit from her presence and really look forward to seeing her. We're all struggling a bit to support her as best as we can through this, and I just wanted to be transparent so you can be as understanding and compassionate as possible. Maureen and I are already anticipating having possibly a few tears on site, so just wanted to prepare you. So Maureen, we're very fortunate to have as the Chief Logistics Officer Extraordinaire. She'll be making sure we all arrive in Chicago and have adequate meeting space and materials for the training, coordinating evaluations of the sessions, and she's assembling some great materials to prepare you in advance for Chicago. So for course preparation, we have these 2 webinars that'll lay the groundwork for what will be covered, this course intro, and then next week, Deb Rosenberg will be providing a lecture on the statistical and epidemiologic framework as kind of a stats refresher in advance of the course. We also have some required and optional readings. There's very few required. I believe it will be just 1 for propensity score and 1 for evaluation. We will be sure to let you know in advance in that before you go email that Maureen will be sending. So in the in-person training, we have this list of lectures. I believe the course agenda will also be sent in that email from Maureen. And we'll have exercises embedded in all of these lectures and 3 small group exercises. So we'll have an icebreaker on the first day, and then 2 exercises, group exercises for program evaluation. We'll also be having some group discussions of individual projects, and Maureen sent out an email to just gather some basic information about a potential project you might want to undertake. This really doesn't have to be extensive. I think we're still waiting for a few of your responses. It could be just as basic as an outcome or population that you're interested in. It can just be very minimal. We just need some kind of information to help group kind of similar topic areas. And then we'll also be having faculty Q&A and individual technical assistance on Wednesday and Thursday. After the course, we'll have 2 post-training webinars to really extend the on-site training. You'll choose 2. Here's just some examples of topics we're not covering this year that I noticed many of you were interested in your applications. So we'll be querying you and selecting the 2 that we'll be providing after the course. But a lot of these topics we do have archived as well. So if there's anything that's not covered, we can definitely refer you to other resources and information. And we have ongoing technical assistance as part of this course. So you can feel free to reach out to any of the faculty members about projects you're working on and any questions that we can help to assist your work moving forward. After a year, we do a kind of a post-training evaluation to really evaluate the impact after a year, what technical assistance you might have sought, your current employment, skills acquired and strengthened, and really examples of impact of projects and products enhanced. And we really value your feedback as part of continuous quality improvement. It's essential, and we have, over the years, really provided a lot of enhancements to the course to improve the quality. So these are some examples. We've learned that when the training was kind of more general, about a quarter would be bored and not stimulated, and a quarter would be just lost. And so now we have it targeted towards a basic to intermediate skill group and an intermediate and advanced. And there's still variation within these, but it helps the training to be a little bit more effective. So you all in this intermediate and advanced year have a lot of experience and skills and are really moving into more advanced techniques, and that's what we'll be covering this year. We've also learned that it's good to offer this advanced technical assistant sign-up so that we can match you with the appropriate person or faculty member and organize similar requests so you can all benefit from that discussion. The networking opportunities are really what a lot of trainees get the most out of, learning from each other. And so we've built that in to have more outings and lunch discussions and a career mentoring discussion as well. A photo roster was a new request, and that's been extremely helpful. I think it's just the second year we're doing that, and it's really great to get to know one another and not have to ask the person multiple times their name, and just to be able to have it as a nice resource there. And by the way, really, Maureen already has that together, and we'll send that out, but your headshots are great. You can really see your personalities, and excited to meet you all. We have also learned it's best to cover fewer topics in greater depth, and that's something we continually try to do, to not cover so much, but really focus. And I think we're getting better and better at that every year. And last year, we also had a request that we're applying this year for you as trainees to bring individual projects, so you can try to apply that material on site and make those connections and hopefully continue that learning and technical assistance after the course. So here are just some success stories and examples of impact that we've had from previous trainees. So you can see here some comment on the Title V needs assessment and incorporating that training and using target setting for block grant measures. Someone added a section to an annual report showing the number of infant deaths attributed to disparity. Their next quote is a trainee who actually published an analysis in pediatrics and says she was really struggling with how to do the modeling, and the instructors really helped to clarify her thinking and how to approach it and what pitfalls to look for. And then the next quote is actually from a trainee from last year, and this really resonated with me. They're commenting on looking at small multiples, so effective data translation and presentation. So they got something out of that. And then this quote, each conversation I have with colleagues and interns about workload, being overworked and setting priorities, I bring up consequential epidemiology. I've been able to guide my director toward, in a way, certain projects based on these conversations and what would be meaningful for our jurisdiction. It helps us all prioritize given time barriers. And that's what resonated with me, because we are all faced with time crunches and limited time to conduct research. So we really do have to be strategic about the projects that we take on and make sure that we're focused on those that are going to have the most impact in improving programs and ultimate health in the population. So just a little bit about you. The class of 2018, we have 42 trainees from 29 states and territories. 25 of you are in state and territorial health departments, and 13 in city or county health departments, and 4 in tribal epicenters. The average age is 33 and a half. 81% are female. We have 8 males. That's actually more than we normally have, so that's nice to see. And we have a lot of diversity as well. And we have 8 previously trained folks that are coming back this year who may have done a basic intermediate in a previous year. And this map really shows kind of where you're all located across the country, coast to coast, in every HHS region and as far as Palau. 10 states have multiple representatives, as many as 4 in California. We also have 5 states indicated by the hash lines that have trainees at both state and local levels, which we really like to see to help foster that collaboration and synergy at state and local levels. So these are just, it's a word cloud of programs and data and topics that were listed in your job responsibilities. So we can see here that the Title V MCH Block Grant is one of the largest mentions. We have increasing mentions of maternal mortality and neonatal abstinence syndrome compared to previous years, and that really is corresponding to some increases in those indicators. We have increasing need to address those for sure. We have home visiting, family planning, school health, PRAMs listed there, and during the lunches we'll have some tables assigned to different subject areas and topics to help facilitate that peer-to-peer exchange. So just some tips to get the most from the course. attending these webinars, which you're doing now. That's great. Really using the opportunity to focus. So it's rare to get a week where you can really focus away from work on your development. And you may still have, obligations to your work, but try to keep that, to after hours, and so you can really focus on your development as much as possible. Really network with one another. Again, that's one of the most valuable things that trainees mention about the course is that opportunity for that peer-to-peer exchange and sharing tricks and tools. And so we will have this reception on the first day, a kickoff to get to know one another. We'll have these lunches throughout the week, and an outing that we'll be planning on Tuesday. And then many of you will continue to plan outings for the rest of the week, and may form, lifelong friendships. We've heard about that from folks in the past as well. There will be a lot of material. Some of it can be a stretch. It may be overwhelming, but just try to focus on what you can get, and we have many references to help continue that learning, and all of the faculty are available afterward as well. Really key to ask questions that can help facilitate learning not only for yourself but collectively for everyone around you. And it's a safe space for a welcoming community. There are no dumb questions. And really seek that technical assistance during and after the course. Okay, so now we have a poll. So I guess, Maureen, I don't know if okay, we do have, I can't see the poll, but I think you can. So for the group outing.
Wow, actually, Ashley, I can't see it either, so I'm just going to have
Well, it looks like the first box is baseball. So let me just say the first box there is a White Sox game. We could do that on Tuesday. The second box is there's a Tuesday on the Terrace. It's a jazz concert at the Museum of Contemporary Art. It's really more, I think, like kind of a background concert. You can have dinner and still do a lot of mixing and mingling, and we can make a reservation in advance for that. So if you all can select A, again, the first box is baseball. The second is more of an intimate jazz setting at the Museum of Contemporary Art. And Fiona had a false vote apparently here. I don't know that you can do that, but we can take account of that. What would you like to change it to, Fiona?
I'd like to change to the jazz.
Okay.
I like baseball too, but either one's
really
good.
So we're now 50-50 then if you're changing. This is going to be tough. Well, I think we have all of the responses in.
Hello?
We have all of the responses in, and with that change, it would be equal. And so we may have to make an executive decision. I know that there are more White Sox games throughout the week, so maybe we will just go with the Jazz Tuesday since that's the only option to do that. Okay. So just a little bit on additional training and data resources that I just wanted you to be aware of. So the Bureau sponsors 2 webinar series, Data Speak, that features topics related to MCH data, and Enrich, which stands for Research, Innovations, and Challenges, that feature topics related to MCH research and methods. And so here are some examples of topics we've covered that I think would be of interest. For example, linkages or some visiting research or maternal health. qualitative methods. So these are all archived and are a good resource to check out. The MCH Navigator is something that we sponsor through Georgetown University, and this is really like a one-stop shop that has, all of these various archives, including the webinars I just mentioned, included here. They have different training bundles, like for epidemiology, for program managers and those who are actual analysts or data makers, as they call them. Some of our course material is actually archived here and includes additional topics that we aren't covering this year, at least on site, like missing data analysis or multi-level modeling. Some additional, I forgot to mention before too, our website has different listservs that you can sign up for on for epidemiology and research too at that link. So here are some additional training resources. You can sign up for the CDC Epi listserv and ground rounds at that link, or sending a message with the subject heading subscribed, mchepi@cdc.gov. The AMCHP, the Association of Maternal and Child Health Programs, they have an archive of their annual skill building training, and they are really the representatives of state MCH programs. And they also archive trainings that are in advance of the MCH Epi conference and have a TA program as well. CityMatch has a lot of great resources as well. They have perinatal periods of risk training, and they can take TA requests too. And then there's a website here, mchepi.org, which has code sharing and offers some peer exchange platform as well. But I did notice that website is currently under maintenance, so just so you know. Here's some general data resources that I'm sure you're already familiar with many of these, but something may be new here, hopefully. And if you have additional resources, please feel free to just type those into the chat box. The Healthy People charts a course for the nation and states and has key indicators over a variety of domains, including maternal and child health. The site is linked to data and contains information on interventions and resources. I use it a lot. County health rankings, you can compare counties in a state or in a nation on outcomes, behaviors, clinical care, socioeconomic factors, and physical environment. The Title V information system allows you to see current performance and outcome measures for the state MCH block grant, a ratio of spending between different services. You can look at your state's application and narrative and do different keyword searches as well. MCH Data Connect, that's at Harvard. It's kind of useful to identify different data sources, so you can view that by geographic unit or topic and do advanced searches that way. Peristats is a March of Dimes database that compiles various perinatal indicators and has them by region, state, and sometimes city and county. The nutrition, physical activity, and obesity data, it is also a CDC resource, and they have a lot of information on breastfeeding, physical activity, and obesity compiled, and you can also drill that down to look at state-level data. Some administrative data sources that are commonly used, vital records, of course, and these are links to where you can access these. census, population counts, WIC, nutrition program, Medicaid claims data, and hospital discharge. These are all, really valuable sources of population level data, and many of these, with the exception of the census, you can obtain directly from your state, and they're even more valuable when you're able to link them across data sets as well. Okay, so some survey data sources that are available, of course, the Pregnancy Risk Assessment Monitoring System that tracks behaviors and experiences and outcomes before, during, and after pregnancy. The Youth Risk Behavior Survey, which is unique in asking youth themselves to report on their behaviors and experiences, and there's actually new data that will be released tomorrow. So that's extremely timely to have 2017 data just 6 months after the close of that year. The Behavioral Risk Factor Surveillance System is really the partner or survey for adults. National Immunization Survey, where we get a lot of information, of course, about immunizations, but also about breastfeeding practices. And the National Survey of Children's Health and Special Healthcare Needs that I'll talk about a little bit more in the following slides. So the first two data sources are those that you can obtain directly from your state, and the latter three you can have access to the raw data files directly from those links. So the National Survey of Children's Health, that's sponsored by our Bureau. It's a parent-reported survey of children 0 to 17, and it's really unique in providing national and state-level estimates of children's health, really capturing physical, behavioral, emotional, contextual healthcare access, and for CSHCN types and impacts of the special healthcare needs. It informs 19 Title V measures and 15 or more healthy people measures. It was recently redesigned. It was previously conducted only every 4 years, and now we're fielding it every year to get that more current data, ongoing data for trending, having that annual estimate, and we'll have rolling estimates for states. It merged content for all children, including special healthcare needs, and it became a mailed survey. Previously was a phone survey, and that was really due to declining response from the cell and landline phones. And we also have a lot of content improvements, for example, capturing new items with school readiness and early childhood development. So where you can find out more about the survey, here's our website, and there's links to you can actually view the questionnaires and the data sets, and right here there's a link to the Data Resource Center, which I'm going to show you next. And so that is a great resource to really query and look at the data without running it yourself. You can look at preliminary statistics. It makes it much more accessible for all users. And so you can browse the survey by year and select measures and look nationally, across or within states and regions by demographic stratifiers, and sort by state to see rankings. And you can compare data across states, across multiple measures. They have these hot spotting tables. I think I have a couple slides coming up that will show these two features. So here's an example of where you can select a measure and look at all of these different types of demographic stratifiers, and then you can sort by state to see different rankings as well. And this is a hot spotting table that they put together. So These are the Title V national performance measures, and I think it's really interesting to see that it tracks performance being lower or higher than the national rates, and it's kind of cool to see that basically almost every state has areas of strength where they're doing well and opportunities for improvement. So I think it really shows what we're trying to get out of this transformation of our performance measures, and having this be kind of a national laboratory where states can really exchange and compare ideas and learn from one another. Here's one of the maps that they have available. This is the percent of adolescents with a preventive medical visit in the past year. And it's kind of interesting to see this east-west divide here that seems to be much higher on the East Coast than the West Coast. I'm not exactly sure why that would be, but it's interesting. So here's a question I'm just curious about for all of you to see what statistical packages that you use. So we will be able to provide some code and some assistance to you, but it's just kind of helpful to know the breakdown of where you are so that we can focus our resources accordingly on site. Okay, so it does look like 90%, wow, do use SAS, and these are not accumulating to 100 because it says check all that apply, but that's good to know because I think SAS is our default for a lot of the code that we provide. I also do provide quite a bit of Stata code because I do find personally that it has a lot more options and add-on packages that make modeling a little bit easier. But coding I still find to be easier in SAS. More and more we are seeing folks using R and Stata. R is a freeware package, so there's no cost to using it. Stata, there is some cost, but it's a perpetual license, so it's cheaper than SAS, which requires an annual license. Is definitely the most expensive. And a fair amount are using SPSS. I personally don't have a lot of experience in that, but I believe Pat Ocampo may be familiar. Okay, thank you. So in the remaining 15 minutes, I'm just going to give kind of a quick overview of the Bureau, Maternal and Child Health Bureau, where I sit. A lot of people, I was surprised to learn in previous courses, think that it's part of CDC, and it's in totally different agencies. It's part of the Health Resources and Services Administration, one of 5 bureaus there. And that HRSA is also known as the Access Agency, the nationwide network of community health centers that provide health care regardless of the ability to pay, is the largest program. But here's our kind of mission and vision and approach statements that I just noticed were actually recently updated, and it's kind of cool to see that the approach actually acknowledges and references kind of data-driven approaches to achieving this vision of a healthy America for children and families that are thriving and have a fair shot to reach their fullest potential. And about 85% of the funding does go to that Title V block grant, which I'll show in coming slides. The rest goes to these discretionary grants, including this training course, these special projects of regional and national significance. So I wouldn't be a bureaucrat if I didn't show you this nice little org chart. But here at the helm of our organization, we have Laura Kavanaugh. She's been with the Bureau for over 15 years, and she was previously the Deputy Director to Dr. Michael Liu, who resigned in October and is now with Georgetown, or he's now with George Washington. Laura used to be at Georgetown University for about 15 years before coming to the Bureau, and she's held various leadership positions throughout the Bureau during her tenure here. We have all of these different divisions that are focused on particular populations and issues like workforce development, for example, and programs like Healthy Start and home visiting. Division of State and Community Health oversees that block grant program, and I am here in the Office of Epidemiology and Research, supporting all of those other divisions and programs. So our office is directed by Dr. Michael Kogan, and we have these office goals to build the data, research, and analytic capacity at national, state, and local levels. And we do that really through that survey primarily, the National Survey of Children's Health, supporting the annual training conference and training course is an example of strengthening and developing the present and future workforce. And we conduct, support, and disseminate research to strengthen the evidence base through an intramural program as well as an extramural research program, research grants that go to a lot of academic institutions. And we provide that analytic support to inform the planning and evaluation of Bureau programs and initiatives. So here are like 4 examples of programs I'm just going to provide a little overview of. The largest, of course, is that state Title V block grant program. Home visiting and Healthy Start are our next largest programs. And then COIN is just a model of collaborative learning that we're trying to apply to a lot of our programs and topics. So just a little background on the Title V Maternal and Child Health block grant program. It was authorized as part of the Social Security Act in 1935. It's the longest federal-state partnership to improve the health of all the nation's mothers and children. And it's really the largest source of broad-based public health funding for maternal and child health. It was consolidated from 7 different categorical programs into a block grant in 1981. I mentioned this before, but 85% of that funding does go to the block grant. And it's a 4-to-3 federal-state match program, so it results in over $5 billion of funding annually. And it's in all 50 states and 9 jurisdictions. States complete an annual report and application and do a 5-year needs assessment to identify and flexibly address MCH priorities along those different population domains. And so here are just some of the legislative goals. I won't read them aloud, but it's really, there's a lot to really improve access to services, specifically to reduce infant mortality and services for those with special health care needs and vulnerable populations. Here's the MCH Pyramid of Services. So we do provide some direct services as a payer of last resort and have these enabling services to access direct care, translation, transportation, case management, and then public health services and systems, and that's supporting population-based services and infrastructure like needs assessment and various policy and program development, evaluation, and quality improvement. So this is a new Title V performance measurement framework. It went into effect in 2015, but we really applied an evaluation logic model to it where we have at the heart these 15 national performance measures that states select. They are now selecting 5, 1 in each population domain, and these are really short and medium-term outcomes that we feel like we can make more immediate progress on some behaviors, some access to care indicators. And these feed into broader, longer-term outcomes of morbidity and mortality that we're tracking in relation to those performance measures. And then states are quantifying their activities and strategies in these kind of process measures or inputs and outputs. And we call these evidence-based or informed strategy measures. So this is a chart just showing those 15 national performance measures across those population domains. And we have the Title V information system I mentioned before, but here you can really go and look at your state's performance measures and outcome measures. And so here's an example from Illinois. They selected the Well Women Visit for their maternal women's domain measure. And so you can see the trend, which there really doesn't appear to be one there over time. So we're really hoping to see improvement beyond the latest year here we have is 2015 when it went into effect. And so you can see these improvement objectives that the state has set there. And also just want to mention this SAD resource document that has more measured details and all of the state data by stratifiers with SAS code, so you can run any indicator on a more granular level in your state or community. We're kind of running up against time, so I'm not sure if I'm going to, we have one more poll. I may not list out all of these bullets here, but really home visiting is one of our largest programs. It was authorized in 2010 and recently reauthorized under CHIP. It has grants to 55 states, territories, and nonprofits, and really applying these evidence-based models to serve pregnant women and families and promote child development, maternal and newborn health. We have these 6 benchmark areas for improvement. And there's a national evaluation underway as well. Healthy Start was really designed to improve birth outcomes, and we have 15 grantees expanding from 15 in 1991 to now 100 grantees. And they have a focus on 5 key aspects to improve women's health before, during, and after pregnancy, and a number of other areas addressing social determinants to really improve those birth outcomes. And there's also an evaluation underway for the Healthy Start program that some of you may be participating or aware of as well. And we're using PRAMs and linking with vital records to do that. COIN, many of you may have heard about this, and I have one final poll coming up on this, but it's really, as I mentioned before, a new model, a way of doing business, and it provides both a platform and a methodology to achieve improvement. So we have this usually a virtual platform to connect folks across states, and it's like kind of a virtual hub to learn collaboratively and apply quality improvement methods to advance those shared aims through evidence-based and innovative strategies. So really the key elements are having these common aims and objectives, applying evidence-based and innovative strategies, and being able to track progress in real time to know what's working and what might need refinement to achieve further success. It first launched in 2012 at the request of Southern state health officials to address infant mortality, and it has since expanded to a lot of different programs and topics across the life course. So we have all of these listed here, and we have a final poll coming up just asking about which COIN you may be participating in. Okay. So we see a lot have participated or are participating in the mortality coin, a lot in maternal health. So that's great to see that about 2/3 of you are participating in these. So this is a common topic that we can discuss, on site and kind of learn from each other about our experiences and how we can improve. And I can take your feedback federally as well. So just a couple final concluding thoughts. I forgot about these slides. I thought we were going to be done right at 4, but just 2 minutes here for consequential epidemiology, and that's a theme we'll hear, throughout the week I mentioned earlier. And it's really kind of getting back to the roots of epidemiology and, thinking that it's to understand the distribution and determinants of disease, but that's ultimately to help us intervene and optimize health and reduce disease. So we really have to be thinking about that action step in informing programs and policies. Just thinking that methods are tools that are useful only to the extent that they serve a purpose. You're going to learn a lot of fancy techniques. Not all of them are really necessary to answer a given question. So it's not being seduced by a method. There's a lot of kind of glittery tools we'll learn about, but really have to think of the purpose and what method will serve that. So descriptive statistics can be very helpful and simple. The who, what, when, where, and why. Who, what, when, where of disease, just disease patterns that can identify program targets. We extend that to multivariable statistics, the why and the how, to really identify independent determinants or causal effects for modifiable factors that we can change and intervene on. We can assess contributors and trends to disparities as well. Really asking those kind of critical questions. And that's what you want to think about is the purpose, the so what factor. What are you going to do with a given analysis? Do you have that buy-in from stakeholders who will be using that information? Has it been done before, or are the results likely to be different than findings from previous studies? Or there may be national studies. Is it really going to be different in your community, or can you apply kind of a causal effect estimate? And that's something Bill Sazenfield mentions a lot with, in particular with perinatal periods of risk, that you can take these effect estimates from other studies and apply them given the distribution and prevalence of factors in your community to see their likely impact. And we'll discuss that more on site. But a lot of times too at state and local levels, you may have very unique data sets that you can answer questions that we can't answer federally, for example, because you can do lots of cool linkages. And then just thinking about a question being, is it etiologic or risk factor focused versus trying to go to the next step and quantifying the population contribution or potential impact of an intervention? That's getting us to being, more consequential and informing actual efforts and interventions. And we always have to think of, the end at the beginning. What's the, goal and dissemination translation plan? And we'll be talking a lot about that with knowledge translation throughout the week as well. So with that, I will end this webinar and just say I'm really looking forward to meeting you all in a week and a half in Chicago. Thank you.
Thanks, Ashley. Thank you so much. And thank you, everyone, for hanging in there. We had 34 people, I think, at the beginning, and we still do, which is pretty awesome. Next webinar is next week, same day, same time. And then we'll see you all on site Monday, June 25th. And as Ashley alluded, you'll be getting an email with a whole bunch of information in the coming days. And finally, if you have any questions, don't hesitate to call or email me at CityMatch. Have a great day, everybody. Thank you. Bye-bye.